Okay, hello everybody. I'm back. Now we're going to be talking about peptic ulcers, the pathology, and how aggressive factors will do our defensive factors of the belly in. And the first thing we're going to talk about is Helicobacter pylori, or H. pylori, another crazy name for a bacteria that's specifically found in the gut. It is gram-negative bacteria that can colonize the stomach and the duodenum. It takes place between the mucus layer and the epithelial cells, so it escapes destruction by acid and pepsin. It's a very smart bacteria that way. It can remain in the GI tract for decades. Your textbook says that half the people in the world have this in their gut. Most infected people do not get peptic ulcer disease, but the interesting thing about that is that 60 to 70% of people with peptic ulcer disease have H. pylori. Second to bacteria, it promotes ulcer healing. Oh, I'm sorry. Second to, never mind that. 60 to 70% of people with peptic ulcer disease have H. pylori, or this bacteria that's specific to the belly. It's second to duodenal ulcers. It's more common for H. pylori with peptic ulcers. The third, eradication of the bacteria promotes ulcer healing. And fourth, eradication of the bacteria minimizes ulcer reoccurrence. They don't know why this bacteria causes ulcers, but they hypothesize that the enzymatic degradation of the protective mucus layer, infiltration of neutrophils and other inflammatory cells in response to the bacteria's presence. Also, H. pylori produces urease, which is an enzyme that forms carbon dioxide with ammonia. Both compounds are toxic to the gastric mucosa. Pelvic, listen to me, you can tell I'm an OB nurse. Peptic ulcer disease promotes gastric cancer. They've declared, and by they, it's the International Agency for Research on Cancer. They have declared H. pylori a type 1 carcinogen. So there you have it. Okay. So that's H. pylori, aggressive factor. NSAIDs, we know what NSAIDs do. It inhibits prostaglandins, and those are non-steroidal anti-inflammatory drugs. And we know that we need prostaglandins because it stimulates the secretion of mucus and bicarb, and it also promotes vasodilation, which helps maintain that submucosal blood flow. So NSAIDs, even though they're awesome drugs, not very good for people with ulcers. And then gastric acid, a requirement for ulcer generation, obviously. If we have too much pepsin, gastric acid activates pepsin. And smoking. Smoking is, for whatever reason, actually helps initiate more gastric acid and pepsin. Okay, so looking further into peptic ulcer disease, we know any ulcer is a break or an ulceration, a hole in the protective mucosal lining of the lower esophagus, stomach, or duodenum. So the peptic ulcers are the high ulcers in the gut. They can be acute or chronic. They can be superficial or deep. And superficial, it's just going to erode the mucosa a little bit. Deep, penetrate and damage the blood vessels way past the mucosa layer, causing hemorrhage or perforation of the GI wall. And there are three types of peptic ulcers. There's duodenal, gastric, which would be stomach, and then stress ulcers. And then here's a picture. They're chronic peptic ulcers. So that's a deep hole in that mucosa, as you can see. And it also shows you the size in centimeters. That's fairly large. Okay, so now we're going to look at who gets these. Who gets peptic ulcers? Incidence about 5 million people. Wow, in our United States. Risk factors, again, smoking. We already talked about the H. pylori, gram-negative bacteria infection. Habitual use of NSAIDs. We know why, because it diminishes prostaglandins, which is a defensive factor. In the belly, alcohol use, that's ETOH, chronic illness, just because the whole body is not going to be responding well. And they're more apt to get a lot of things. RA is rheumatoid arthritis. They look use a ton of NSAIDs, usually to maintain the joints in rheumatoid arthritis, emphysema, and cirrhosis. And you can see those are all chronic illnesses. Psychological stress, persistent anxiety and depression. And then stress ulcers in ICU especially burn patients, such as stress on the body. Statistically, it says 78% will develop stress ulcers within 72 hours. A burn patient if they're burned over 35% of the body. So clinical peptic ulcer disease, most common of peptic ulcers are duodenal ulcers. Developmental factors, again, major cause is H. pylori infection, toxins and enzymes that promote inflammation and ulceration, hypersecretion of stomach acid and pepsin, the use of NSAIDs, it's almost like a repeating theme here, high gastrin levels, which is going to promote acid, and acid production by cigarette smoking. Usually it's relieved by eating or antacids. Pain is caused usually with duodenal ulcers when the stomach is empty. Peptic ulcer treatment is aimed at relieving the causes and effects. Would be aimed at relieving, again, what's causing it. Antacids will neutralize the gastric context, elevate the pH, and inactivate pepsin and relieve pain. So there you go. Histamine 2 blockers block the action and secretion of acid. PPIs inhibit acid production. Bismuth, metronidazole or clarithromycin, and amoxicillin or tetracycline for H. pylori will prevent a relapse, or for H. pylori only, Flagyl, Biaxin, and Protonix for 1 week. Let's see. Ulcer coating agents will promote healing because we're going to coat the ulcer with almost like a protective substance that keeps the acid away. And then anticholinergics will inhibit gastric secretion and decrease motility. We'll be talking a lot about these medications in the lecture 4 medicines, but I just wanted to list them for the peptic ulcer treatment. So clinical manifestations, chronic intermittent pain in the epigastric area. Pain usually begins 2 to 3 hours after eating, so they have food on board when the stomach is empty. Pain can occur in the middle of the night. Complications are always going to be with any ulcer: bleeding, perforation, or an obstruction. Bleeding, we can have either hematoemesis or melena, and again, hematoemesis is usually going to be bright red, or melena is going to be dark or black. Tend to heal spontaneously, but they recur frequently for peptic ulcer disease. Okay, now we'll talk about the gastric ulcers, which are not quite as common as the duodenal ulcers. It tends to develop in the antral area of the stomach, region of the stomach, adjacent to the acid-secreting mucosa of the body near the parietal cells. Both male and females get this, and this is 55, 65 years old. And again, not as common. Duodenal are the most common peptic ulcer disease. The primary defect is an increase in mucosal permeability to hydrogen ions. Gastric secretion tends to be normal or less than normal, and pain occurs after eating. Causes more anorexia, vomiting, and weight loss than duodenal ulcers. It's relieved by ingestion of food or acids. Okay. And then a stress ulcer, and we kind of referred to it as the burn patient, is related to severe illness, neural injury, or systemic trauma, meaning all over the body, which would be our burns. And there's 3 different types of stress ulcers. We've got our ischemic ulcers that develop within hours of events such as hemorrhage, multi-system trauma, severe burns, would be our ischemic, heart failure, or sepsis, decreased blood flow to the gastric mucosa. Curling ulcers are ulcers that develop as a result of a burn injury. So the burn actually is going to fall under ischemic end curling. And then a Cushing's ulcers that develop as a result of severe head trauma or brain surgery that results from diminished or decreased mucosal blood flow and hypersecretion of acid caused by overstimulation of the vagal nuclei. So you can see that our blood flow, I mean, we just got done with cardiovascular, is very, very, very important throughout the body. Because any of these can happen due to ischemia. Clinical manifestations of a stress ulcer is going to be bleeding in the gut. A prophylactic treatment, they're going to try to, so this doesn't happen, suppress it with antacid and our proton pump inhibitors, which I'm going to talk about after this lecture. Stress ulcers seldom become chronic. It's just in response to the stress that's that's happening to the body. Okay, now we're going to talk about malabsorption syndromes. And so what is that? That's basically what the large intestine is for, is it can't absorb the nutrients that we need, the water that we need to maintain hydration and nutrition. And here it is, maldigestion or malabsorption. They're used a lot of times frequently together. Maldigestion, failure of the chemical process of digestion. Something's failing. Malabsorption is almost even bigger to some extent. Failure of intestinal mucosa to absorb digested nutrients, usually caused by diarrhea. And again, they can be used frequently, they're seen together. So some of the more common ones are pancreatic insufficiency, when we don't have, when the pancreas cannot produce the enzymes that we so need in our body for digestion. Lipase, amylase, trypsin, or chymotrypsin, very, very important. Causes include pancreatitis, pancreatic carcinoma, whenever there's cancer of the pancreas, pancreatic resection if they have to take part of it out because of a cancer, and cystic fibrosis. They have a lot of problems in cystic fibrosis with pancreatic enzymes. They just don't produce them. Fat maldigestion is a main problem, so the patient will exhibit fatty stools and weight loss. Another malabsorption syndrome is lactase deficiency, which is an inability to break down lactose into monosaccharides and therefore prevent lactose digestion and monosaccharide absorption. So they just can't break it down. Fermentation of lactose by bacteria causes gas and osmotic diarrhea, which is very cramping, pain, and gas in the gut. And then another one that's very, very common is our bile salt deficiency. And this is conjugated bile salts need to emulsify and absorb fats, and that's usually in the liver. Conjugated bile salts are synthesized from cholesterol, there it is, in the liver, can result from liver disease and bile obstructions. Because bile, or bilirubin and bile, they're both conjugated in the liver. Poor intestinal absorption of lipids causes fatty stools, diarrhea, and loss of fat-soluble vitamins A, D, E, and K. And they're very important vitamins. I mean, most vitamins are, but vitamin A deficiency can cause night blindness in anybody, not just the elderly. Vitamin D, decreased calcium absorption with bone demineralization. We know we need vitamin D and calcium, they go together. They can have bone pain and fractures from a deficiency syndrome of vitamin D. And it could cause osteoporosis or bone softening. Vitamin K, we know, prolongs prothrombin time, leading to spontaneous development of bruising and petechiae. So it can cause bleeding if we have a deficiency of vitamin K. Vitamin E can cause testicular atrophy and neurological defects in children. Anyway, so how are we going to treat this? We're going to treat it with bile salts of oral vitamin A, D, and K. That's how we're going to treat that malabsorption syndrome. Okay, I'm going to stop right here and we'll go on to the next part. This will be the end of the video 2 for gastric dysfunction.